Welcome to yet more webinar by the Gujarat WhatsApp Pediatrician Group. This is the 20th webinar in a row. We started in March 24 after a lull of the COVID time. And then we have, except for the election months, we have always had one webinar. And during TB discussion, we had two webinars back to back. Today we are here to discuss about the interesting cases in pulmonology. And since last time we have started this series where we'll invite moderator as well as panelists from each faculty, and myself and Dr. Ramesh will take a backseat sort of and let them do the discussion. So we have a very able moderator in the form of Kaustubh Mohite. Kaustubh works at Panvel in Dr. Mohite's hospital. He's attached to several hospitals, including PD Hinduja Hospital, where I am the head of the department. So we are very happy to have him. I mean, he has done some inspiring research work, which has won a lot of laurels in the form of best paper awards in various national and international conferences. And his special interest is in diagnostic and therapeutic bronchoscopy. In fact, on some of my own patients, he has done that in Mohite Hospital, especially the EBUS and the EBUS-based biopsy. I mean, instead of doing a CT-guided biopsy, you can do a transbronchial biopsy. That's something which is very famous for. And many times we do, again, a biopsy. You can do actually a biopsy of a pleural tubercle, that precise, and, give you the diagnosis. So, welcome, Kaustubh, the youngest of the faculty, but I'll tell you once you see the today's proceeding, he's one of the best. Okay, we have
Thank you, sir.
our own Dr. Hiren Trivedi Bhai. Hiren Bhai works in Ahmedabad. He's basically a intensivist and also interest in the pediatric pulmonology. He's a diplomat of the American Board of Pediatrics. That's something great. And he's also now the fellow of the American Academy of Pediatrics. He has worked in Columbia University in New York in the past and has been the ex-assistant professor at the Department of Pediatrics of the State University of New York. So that's something to add to his lot of laurels. At present, he is working as an intensivist, as I said, since 2006. That's almost 20 years. And his special interests, as I said, are in sepsis, onco critical work, and also the pulmonology. So welcome, Hiren Bhai, our own person from Gujarat. Next, we have Dr. Pallab Chatterjee, my friend from Kolkata. Pallab is one of the pioneers in respiratory medicine and bronchoscopy in Kolkata. He has done his diploma in pediatric sleep medicine at the Colorado University, and he has been at the European Diplomat of Pediatric Respiratory Medicine. So, a lot of laurels. He has held various positions in IAP as executive board, as a chairperson of the Computer and Medical Informatics chapter. Uh, Worked at the state level, at the city level in Kolkata, and at the central level. Several papers, scientific papers he has published, and he is one of the, as I said, pioneers in bronchoscopy in Kolkata. So welcome, Palab. And last but not the least is Dr. Ankit Parag. I mean, who doesn't know Dr. Ankit Parag? He is an associate director of pediatric pulmonology, allergy and sleep medicine at the BLX Max Hospital in New Delhi. And I think there is hardly any conference either in general pediatrics or in pulmonology where you would have not seen Ankit speaking on some or other interesting topic. His special interest is again in pediatric bronchoscopy and sleep medicine. And his major achievements are that he has been European Diplomat of Pediatric Respiratory Medicine, ERS Sleep Fellow at the Great Ormond Street Hospital in UK. He has been the APSR Fellow Sleep Medicine at Brisbane in London, UK, RCPC London, UK, and pediatric allergy training in the Imperial College of London. So as you can see, we have an absolute galaxy of faculty today, and let's make the best use of them and having case discussion on the interesting cases in pulmonology. I will just hand over mic to Dr. Ramesh Bajania, the founder of the Gujarat WhatsApp Pediatrician Group and a brain behind this webinars, seminars, and all sorts of what do you call scientific exchange that happens between the pediatrician, not only of Gujarat now, but all over India, as the Gujarat Pediatrician Group has now members from all over the country. And I introduced our youngest scientific coordinator, Dr. Krunal Shah from WAPI, who has now taken over a little burden of my and Dr. Ramesh shoulder by looking into this webinars nitty-gritty and day-to-day working. So
Thank you,
over to
sir.
Dr. Ramesh Bajania before we hand over mic to Kaustubh.
Mm. Thank you, Dr. Nitin Shah, sir. So let me first thank our members of Gujarat Pediatrician WhatsApp group, because since I created this group in 2015, the members have been so disciplined and contributing to the academics in day-to-day affair, taking from their office practices, the cases, indoor admissions, etc. And special thanks to Dr. Nitin Shah sir for being there since beginning in this group and making my the scientific work very easy by selecting eminent faculties beyond politics, based sheerly on academics, preferably across the zones. So today, as he said, we are in for an academic feast in form of Dr. Parag, Dr. Pallab Chatterjee, and our own Dr. Hiren Trivedi, and moderated by very young, dynamic pulmonologist and intensivist, Dr. Kaustubh Moite. So, not to take much time between academics and you, I'm straight away handing over the platform to Dr. Mahesh, Dr. Kaustubh Moite.
So
Thank
before Kaustuv, you do, we recognize presence of Dr. Pramod Kulkarni, our EB member from Gujarat for the next year, Dr. Manish Mehta. We have Dr. Ramkrishna Paramans, who always attends this webinar. And last but not the least, the proud father, Dr. Mahesh Moite. And what better than for the father to see the sun shining, maybe outshining him. Yes, Mahesh.
My identity changing now. I am
Okay.
Kaustubh's father now.
Oh, wonderful, Chala.
I'll,
Over
I'll
to
take
you.
I'll take Nitin by 1 minute.
Yeah,
I mean,
okay, Ramesh bhai.
we are very much thankful to our colleagues all across the country for giving us such a huge viewership. In fact, one of our program, pediatric hematology by Dr. Nitin Shah, has practically touched 3,000 views.
Oh, wow.
So minimum 700, 800 to it goes to this much figure. I mean, so that is very satisfying, and it vindicates our stand that if you serve pure academics, then colleagues, they appreciate it. So thank you everyone for this laurels.
All our webinars are archived on the Gujarat Pediatrician's YouTube channel, and even this episode will then go in the next 48 hours. And all the webinars runs from March 24 till today are there for anyone to view. So even if you miss it because of a busy practice, you can at leisurely see your program. In fact, as Dr. Ramesh Bhai said, there are 10-fold, 20-fold higher numbers who actually see it after the program is over. So
Yes,
that's the whole idea of archiving this program. All
yes.
right, now let's begin the science. Kaustubh, the fort is yours.
Yeah. Thank you so much, sir. So first, is my screen visible? And am I
Yes,
clearly audible?
yes.
Absolutely, yes.
Okay. Okay. So first, before we begin, I would like to invite my esteemed panelists, Ankit sir, Palab sir, and Hiren sir. So today's agenda is mainly to discuss uncommon causes of common symptoms, to discuss the approach rather than the final diagnosis, to find out what could be the red flag signs and how specific investigations can help us to get specific diagnosis. Then, if we get time, we'll discuss a few spotters as well. As we go ahead, pediatric respiratory medicine has diseases which could be concerning to mainly three organ systems, either the airways, the alveoli, or the connective tissue of your lung, which is your interstitium. So based on the symptomatology, mainly being either wheeze, cough, shortness of breath, or episodic symptom which points towards your airway, something which points towards your alveoli is something like a cough, dyspnea, or hemoptysis, or interstitium, which is progressive dry cough with some exertional dyspnea, fine inspiratory crackles growing over a period of time. So with this basic introduction, let's directly jump to these four cases. So this first case is a 2-week-old male child complains of progressively increasing tachypnea, progressive distress in the last 1 week, there is intermittent cough, no fever. This is a preterm child, 34-weeker, birth weight of 1.8 kg, born out of cesarean section, cried immediately after birth, NICU stay of 1 week in which this child received O2 just by nasal prongs for the first 3 days. Discharge on breastfeeds plus top feeds as the mother says that she was not able to feed properly. Mother noticed that this child has been having baseline fast breathing. There is occasional cough which is progressively increasing even though he was feeding pretty normally. When he was presented to us, he had tachypnea, which was gradually increasing, and now retractions have started to be shown, which is being observed by the mother itself. Now, on first hospital visit, this child is seen to be markedly tachypnic with rates of around 80 per minute, has subcostal interactions, subcostal plus intercostal retractions, room air saturations maintaining barely around 85 to 86%, bilateral V's, but predominantly unilateral V's, which is more on the right side. So with this, Hiren sir, what could be the probable clinical diagnosis having known this child over a period of time, the last 2 weeks?
Yeah, first of all, I would like to thank Dr. Ramesh Vajani and Dr. Nitin sir, for giving me this opportunity to be part of this panel. Coming to our case, this is a newborn baby, about 2 weeks old baby with respiratory distress and hypoxemia. And clinically, on clinical examination, there is a unilateral signs. Two symptoms are worrisome: cough, this early onset, and wheezing, which is also unusual in the newborn. Plus, also it's more on the right side. So these two things are concerning. We can discuss the differential diagnosis of this later on if you would like.
Right. So clinically, sir, what do you feel? Where is the pathology? What could be the etiology?
Etiology looks more like a airway compression causing VQ mismatching lower down, either atelectasis causing the hypoxemia, VQ mismatching, but it probably major airway compression, right mainstem or tracheal compression
Excellent.
causing this.
Perfect. Perfect. So we are actually pinning down to airway amongst the first three that we saw. Airway, connective tissue, alveoli. We're pinning down to airway as number one. Probably having unilateral more findings. So one side of the airway is more involved than the other. So with this, Pallav sir, do you feel this is congenital or it's acquired? Pallav sir, please.
Yeah,
Yeah.
I'm audible. Yeah,
Yes.
Yes, sir. Yeah.
yeah. Sorry. Thank you, Gujarat Group for having this very interesting session. Well, this because this has started so early in life, no? So onset soon after birth and gradually progressively worsening. So I think there's a strong possibility of something being a congenital or a structural airway problem. So an extrinsic vascular compression, maybe a malacia. So one of these would be the first things in mind before I think of any acquired cause.
Right. So as sir rightly said, all these malaysic component, even though they are present since birth, they start presenting over a period of time because the respiratory efforts goes on increasing, the intrathoracic negative pressure goes on increasing. So possibly it could be something which is congenital, acquired less likely. Next, are there any warning signs, Ankit sir?
Uh, so absolutely, see a 2 week old neonate presenting with respiratory distress, which has been there. So this child got discharged, again got readmitted, right? And having significant respiratory distress is definitely a warning sign, right? Uh, I would still consider this possibility of this being viral.
Hmm.
I understand that yes, you have found some differential air entry, but sometimes in newborns it is not very easy. So at the background, you should consider a viral infection, which would be a commoner thing. But yes, your findings definitely suggest that there are warning signs. So a wheeze, especially if you are saying that the wheeze is more of a monophonic wheeze and it is more towards one side, then definitely we are worried for a congenital anomaly, which might be compression to the lower part of trachea, uh, or it could be something like a Malaysia, which you are looking at.
Right. So contemporary to our previous discussion, sir, that could possibly even acquired as even early infections could present like this. And on top of it, if it all this child had some malicious segment, it probably would have worsened it. And then what would be your next investigation, sir?
Yeah, so I think we should talk about what investigations do we have as of now. So I would like to see what are the basic counts, any sepsis screen. Okay, so
So we have our bloods. ABG is 7.44. His PO2s are 98. PCO2 is 28. Bicarbs of 20. CBC showing more or less okay. 10.8 anemic a bit. 16,800, which is neutrophilic predominance. 2.4 lakh platelets. CRP of 24. Sodium of 140. Potassium 3.5. Chlorides of 102.
and
Any inference from this?
yeah, so I think more or less this looks fine. Doesn't really indicate much because in 16,000 counts could be not very high for a young baby. CRPs of 24. So I think blood culture would be important. The clinical condition would be important. Is this baby genuinely sick? Is this baby active or not? So are we seeing any clinical signs of bacterial infection?
There is
And I
no
think-
fever, sir. There is no fever for this child. Even though this child has distress, there is no fever. Intermittent cough. Cough was also not very significant. But the main problem was retractions and distress, tachypnea.
So,
Yeah.
so
So
one
I think-
question, Kaustubh, sorry to interrupt. This
Yes, sir.
child has received steroids?
No, not
Actually,
yet.
because I'm worried about his 18% lymphocyte, because baby is a lymphoid organ. And
Yeah.
if the ALC, the absolute lymphocyte count, is below 4,500, that's catastrophic. Unless, of course, it's precipitated by an infection, then you will repeat it and see. A persistent lymphopenia tells you something wrong with the T cell. So, I mean, of course, it may not be the case in this child, but of course, if you give steroid, the lymphocytes can go down very drastically. So, that's one thing I will keep in back of my mind.
Yeah, very interesting, sir. We didn't think of, but yeah, very interesting. If receiving steroids, the leukocyte will show its change, but no, sir, it hasn't received any steroids.
So can you show us the X-ray of this child, Dr. Kaustubh?
Yeah, so this is the X-ray, sir. So
Yeah. So I think with the X-ray, we are, we would be definitely wiser. So the right lung appears to be overinflated compared to the left lung. Uh, there is some amount of rotation which is there, but I think still everyone would agree that the left lung is more black. The right diaphragm appears to be pushed down and appears to be flattened, right? And
Right.
the heart is shifted more towards the left side, which tells us that the right lung definitely seems to be overinflated as compared to the left lung. Now, if you look at what causes this, we cannot appreciate a differential lobe here. So you can sometimes have a middle lobe congenital lobar emphysema, which can present like that. Uh, but in this X-ray, I cannot, make out that that one lobe appears collapsed and the other is not.
Right.
The other thing which can present like that is a partial obstruction to the right main bronchus and the lower part of trachea, which leads to a ball valve type of mechanism, which leads to hyperinflation of the right side. So, to me, I think the first investigation, if this child is now stable and possibly given some NIV support uh, and is stable in the NICU, then I would consider doing a bronchoscopy.
Excellent, sir. So you actually practically answered all my next questions, but still we'll go a bit step by step. If you're saying possible differential diagnosis could be something like a partially obstructing right middle bronch or right bronchus, which is causing ball valve mechanism and causing right-sided hyperinflation, causing your mediastinum to be pushed towards your left side. With this again, Pallab sir, with this X-ray in mind, would you first this child is requiring NIV. So with that in mind, would you want to shift this child? I mean, would you want to take a risk to do a CT first, or do you want to directly go for a scopy?
No, I would directly go for a scopy because number one, it will, and particularly a flexible scopy, because it will give us, it will evaluate the dynamic collapse of the airways. It will allow me suctioning of the secretions if there are any, and it can be done at the bedside, so it is much more safer.
Correct.
CT, I will not transport this unstable child. So unless the oxygenation, the airway is secure, then probably I will first stabilize this child and then do a CT or maybe a CT angio after doing a bronchoscopy. If the bronchoscopy indicates that there is some sort of an extrinsic compression on the airways, then I would probably plan for a CT angio rather than doing a plain CT.
Any thoughts on echo, sir? Can you find out
Yes,
vessels
and
and
echo
a
echo
vessel
can
which is
also help.
compressing?
Bedside echo can also help if to evaluate whether there is any aberrant vessel that is compressing. So, but whatever
Right.
it is, first I will probably do a bronchoscopy and then take the others.
Excellent. So, one of our diagnoses was differentials were whether there is some vessel which is externally compressing the right mainstem bronchus, causing ball valve mechanism. So we first got a 2D echo done bedside, which showed a VSD, small VSD, but not causing much of a pressure effect. No, I mean normal left to right shunting, no PAH. Now with this, one very good thing that we can appreciate from all our panel is that no, the threshold for bronchoscopy has gone down. So where we know this procedure is going to be helpful, it is right to do it right at that point itself rather than waiting. So yeah, so this child is on NIV support. So these questions have already been answered. Any different take, Hiren sir, from an intensivist point of view? Would you want to risk, would you want to intubate this child, go on to CT, or would you prefer doing a bronchoscopy bedside?
Yeah, I think bedside bronchoscopy is preferable.
Excellent. So all our panelists are in one thing, and that is what we did. And this is something which was completely unexpected that we found in Scopy. So this is a 2-week-old child, bear in mind, and these are the findings. So this is something which is popping up in the right mainstem bronchus. Focusing on the image, there's something which is having sharp edges, which is sitting at the right mainstem bronchus. Any clue? What could this be?
Natal tooth.
Excellent. So this was actually a natal tooth, which was extracted by flexible bronchoscopy. So the most challenging part in this child was that the child was scoped using a 3mm scope, and the 3mm has only 1.2mm working channel. So none of these big Dornia baskets could go through in. So what we used was a ureteric stone basket in order to take out this natal tooth. And as you can see, the natal tooth was less than half a centimeter, so around 4 to 5mm, with all its the sharp edges pointing upwards. So it had created significant granulation tissue at the point where it was stuck in. And as Ankit sir had rightly pointed out way in the beginning, this was causing ball valve mechanism and causing right-sided hyperinflation and shifting the mediastinum to the right side. So natal teeth are usually poorly formed, have a weak root structure, and this can maybe mobile. Often they are lower incisors. There's a syndrome called as Riga-Fede syndrome, in which, because of this teeth, there is ulceration of the lower side of your tongue, which is observed in the very, very early age, and it is recommended to remove as there is risk of aspiration in this child. Later on, when we asked the parents, there were 2 natal teeth which were already removed in this child, and this was the 3rd teeth which nobody found, and hence this was found inside the airway. On follow-up, this child just came for follow-up yesterday, and we took an OMFS reference. They got a skull X-ray, and they saw that there are 2 more teeth which are the base of the teeth are still there, which have not yet erupted. But very soon they will also be coming out, and they will also be needed to be extracted. So this first case was a natal tooth aspiration. So it goes against all our usual things that there is a typical age group for foreign body. Natal teeth can come as early as at birth. So any thoughts, any discussion on this case, or should we move ahead, panelists?
So Kaustav, was the natal tooth seen at the time of birth, or some child needed intubation or something at birth, which probably displaced
No.
it, or what was the reason?
No, sir. So there were 2 teeth, which were seen at birth, which were removed. The parents told us later, after telling that this was the 3rd tooth. So there was no intubation, there was no manipulation. So initially we even thought that whether this was some broken plastic piece of your nasal cannula, something which has gone inside, because it was completely unexpected to have a natal tooth being aspirated at such early age. But yeah, so this was this 3rd tooth which was missing, which was stuck in the right mainstem bronchus.
Kaustav, excellent case. Very rare. Thanks but one thing I just wanted to know whether we could use a cryo probe to get this tooth out.
So the problem with cryoprobe, again, the tertiary setup where this child was admitted didn't have cryo. That was number one. And the second thing was there was no actual surface. Like even if I had cryo, the surface which was facing upwards was very sharp, sir. So while pulling it out, it could possibly cause some mucosal damage while taking it out, shoving it out through the trachea. So from your right mainstem bronchus till the trachea, this tooth was literally suctioned out using the scope, and then this ureteric stone basket was used to hold it in clasp, and then the whole thing was taken out in one piece. So coming to our next, yes, sir.
Other thing, Kaustav, is that with the other problem with the cryo would be that the tooth is a solid substance, and it does not contain a lot of water content.
Moisture.
Even if you have a cryo, this foreign body is not going to stick to your cryo probe.
Agreed.
So cryo is only useful for substances which have a lot of water content. Even for the usual nuts, it is not as good. So it's very good for things like apple or something like this, which has a lot of water water content. The other problem with the cryo is that it has a touch point, right? And when you're trying to extract it, you can lose it.
Yes.
Right.
On the other hand, when you are using baskets, it gives you a good grip. And most of the baskets that we use, they are like something like 2.7 French, which is almost equivalent to 1.1 mm, which passes through all pediatric standard bronchoscopes. And I think we have been using Domia baskets for removal of all sorts of foreign bodies for the last many years. So I think the most versatile tool is the Domia basket which you have used.
Agreed, sir.
Right.
Great. So moving on, this is a 2-month-old male child now presenting with complaints of mild tachypnea for 3 days, low-grade fever which was undocumented, and intermittent cough. This is a full-term child, normal birth weight, for the first 1 month, on breastfeeds, good weight gain, birth weight of 3.2 kg, right now is 5 kg. During this complaints, mother was saying that even she had some viral prodromal syndromes. On examination, this child is active, playful. There were some secretory sounds, nasal secretions, occasional bouts of cough. Air entry is bilaterally equal. However, bilateral wheeze is heard and occasional dependent creps were heard. So just by this, Hiren sir, what would be the clinical diagnosis?
It looks like a classical viral bronchiolitis.
Right. So any warning signs, sir?
Yeah, right now it looks okay. Right now the child is playful and comfortable. There is some respiratory distress, but otherwise child is playful, and if the oxygenation is maintained, then it's fine.
Right. So just apart from the age of being less than 3 months, otherwise has no significant risk factors for him to categorize into moderate or even severe. So Ankit sir, in such case, do we need to investigate anything?
Well, usually no. Usually no. So if you have a child who is not tachypnic and you're deciding to send the child home, then we usually do not investigate. Tell them about red flag signs. If there is slight amount of tachypnea and feeding issues, and you are trying to admit this child, then most people would do might be one CBC and one X-ray. That would be about all.
Right. Any role of PCR, nasopharyngeal PCR?
Well, you can
In
do
this
it.
case,
Well, with a typical bronchiolitis, you can do to see what type of virus it is. Sometimes these are adenovirus, and sometimes they can be causing a lot of problems later. So, if you're admitting this child, then and you do not have a lot of cost issues, then doing one viral panel would be fine.
okay. Pallab sir, would you want to admit this child or just OPD management is fine?
If there are no, as Ankit said, that no red flag signs like severe workout breathing, hypoxemia, feeding well, poor, no other problems, then I would not, but I will admit if one of these come. So, this child would rather be managed on OPD basis, but we have to tell them about the red flag signs and to come back as soon as possible. Or if I find that they stay far away from the from the hospital, it's difficult for them to bring the child, then probably I would tell them to get admitted and observe.
Right. And if at all we are sending them back, any specific line of management?
Yeah,
Or what? How would you manage?
just the regular management of viral bronchiolitis. So um, uh, maybe paracetamol, nasal drops, and if the child is otherwise stable, there is no hypoxia, feeding well, then nothing else. If there is a family history of wheeze and all that, then probably I would ask them to take some salbutamol, MDIs, if it's required. Otherwise, nothing as such. No specific management.
Right, right. But as these parents were super anxious, this child was admitted and given just symptomatic treatment and eventually discharged once he got relatively better. Now, 2 weeks later, this child turns back, and now this child, the mother complains that there is progressively increasing tachypnea. Tachypnea was just better for the time being during discharge, but now this child comes with labored breathing. There is persistent cough, and now this is not able to feed properly. On examination, he is tachypnic. There are both intercostal and subcostal retractions. There is bilateral wheeze. Again, probably heard more on the left side, but in such cases when there is tachypnea, we actually cannot make out. And there is creps heard bilaterally. So, Pallab sir, now knowing this, that this child had gone home, again come back, what would be your clinical diagnosis? Was it the continuation of the same thing, or is it this new thing which has come up?
So I would think that this child is developing a secondary bacterial infection. It could be an evolving pneumonia, or it could also be some congenital anomaly that is going on, like say an airway lesion or maybe an immune deficiency that is there, which is causing this child to worsen. So it could something be added on the previous viral infection, or it could be worsening of the previous. It could be an unresolved viral LRTI, maybe an early interstitial lung disease. So all this is there in my DD. So would need investigations to come to a diagnosis.
Right. So, Ankit sir, how would you approach change as compared to your previous diagnosis? Initially, we were okay to send this child back home. Now, knowing that this is biphasic or probably the continuation of the same thing, progressive, how would your line of management for this diagnosis change, or how would your thought process change?
Yeah. See, so a less than 6 month old, so you have a 2 month old child who gets admitted twice, right, with respiratory distress, and that is definitely a red flag for me. Now, what could be the possible differential diagnosis which we could consider? So, the commonest would be a viral wheeze, right? Goes home, gets another viral, and again wheezes, right? So that would be the commonest thing which anyone would see in clinical practice. He just wheezes, there's a background of atopy. That would be the commonest thing. And there can be a lot of patients where after ruling out mimickers, we have put these children on some controllers uh, with inhaler, spacer, and mask. That group would be the commonest. But having said that, you cannot do that in a 2 months old till you are really sure that you have ruled out atypical wheezing. So the few possible differential diagnoses would be: one, a child got uh, bronchiolitis because of some virus, and on top of that, you got a bacterial bronchitis. So that is one possibility. And we have a similar child who is admitted with us at the hospital as of now. That would be the first possibility. Second possibility could be that this was a virus which leads to prolonged problems like adenovirus, and sometimes these children are getting towards something like bronchiolitis obliterans. I understand you cannot label them before like 2 months, but sometimes that syndrome seems to be developing, and diagnosing that is important because if you pulse them early, they become better. If you spend a lot of time, they enter into a fibrotic stage. So that's the second thing which I would look for. The third would be that um, there is actually a congenital problem, right, which wasn't apparent previously, and it was triggered when the viral infection came. So, can this be a gastroesophageal reflux on top of that getting viral infections? Can this be a tracheal compression because of a vessel or a tracheobronchiomalacia? I would still keep that possibility. And on top of that, when they develop viral, they get more sick.
Right, excellent. So very nicely pointed out. Either it is a progressive, a super added, or some underlying condition which is probably worsening with this with this infection. Hiren sir, how would you want to investigate this child?
So I would like to get some baseline investigations like CBC, CRP to rule out any secondary bacterial infections. Uh, Multiplex PCR, respiratory panel PCR, to look for any adeno or some other opportunistic viral infections, and
Right, sir.
electrolytes.
So basic
X-rays.
investigations, CBC, this child is a bit anemic. 9.6, 12,600 counts with 44 neutrophils, 50 lymphocytes, and 3.4 lakh platelets. CRP of 30, sodium of 138, potassium 3.2, chlorides of 105. Swab negative. Now what? How would you want to do? What next would you want to do?
X-ray chest.
This is your X-ray. Yeah, this is your X-ray, sir. So any specific finding that you could, Hiren sir, you can take this.
Yeah.
Any specific
Well, there
finding
is
which you could see in this X-ray?
some mild hyperinflation. It's more on the left side compared to the right side. There is worsening haziness on the right side, and the mediastinal shadow looks little white. So there might be some paratracheal, I don't know, lymph nodes. Even carina looks little wider to me. if I'm not wrong. So there is some
Excellent.
hyperinflation. Yeah.
Right. So, knowing this, what again with this progressive kind of problem, how would you want to treat this child, sir? Hiren, sir.
Yeah, I would like to continue non-invasive respiratory support IV. I would start a broad spectrum IV antibiotics, considering some atypical resistant organisms, so piperacillin tazobactam or cephalosporin sulbactam. With and I would like to rule out also TB with gastric aspirate, gastric lavage, because the TB is always a differential diagnosis in our
In a
country.
2-month-old, sir? 2-month-old?
Yeah, it can happen. Yeah.
Right. Okay. So, what we did was, as you said, we hospitalized this child, was put on O2 by nasal prongs, IV fluids as he was not eating well. IV fluids. Any role of any nebulizations? Pallab, sir?
Yes, we can give salbutamol nebulization in this child, but we need to actually come to a diagnosis that what is the thing. So I would also consider maybe doing a CT scan in this child and doing an immunodeficiency screen, maybe HIV for the mother and the child. So all this we'll do, and probably consider doing a bronchoscopy and a BAL to evaluate
Right.
what is there.
So theoretically speaking, we read that all these beta agonist receptors usually start developing after 6 months of age. So before that, do we actually these salbutamol, the levosalbutamols, do they actually work in this age group?
Yes, yes, yes. It's now proven beyond doubt that the receptors are there, so we can start early. So there is no question of like not giving it till 2 months of age.
Right.
That is not nowadays. Yeah.
Right. So you start your treatment. After 3 days, there is persistently low-grade documented fever. Now, since this child is being admitted, having 1 or 2 spikes a day, O2 requirement is still there. This child is still persistently coughing. Now, would you want to increase the antibiotics? I mean, make the antibiotics more wide spectrum, or would you want to investigate for now? Hiren, sir.
Yeah, I would like to investigate further.
hmm So, which would be a CT scan?
A CTs first and then bronchoscopy
Right.
if required.
So, So we repeated an X-ray first. A day 4 X-ray showed this was the day 4 X-ray, and as compared to your previous X-ray. So anything, Pallab sir, what has changed?
Yeah, the mediastinal widening is more evident. There is some sort of a collapse consolidation that is happening on the right side, and the left side also, as Dr. Hiren was saying, that there was some evidence of hilar adenopathy on the left side. That is also much more evident now. So
Excellent.
I would rather go ahead do a CT scan, look for necrosis or what is compressing the right side. That is something we need to check.
Right. So that is what we did. We did a CT and we were not surprised to see this huge lymph nodes, which were seen even on the X-ray. And as you can see, the left side, the necrotic lymph nodes were partially compressing the left mainstem bronchus, which was causing hyperinflation of the left lung. And so the mediastinum was slightly shifted towards the right side. So as reported by the radiologists, it showed multiple conglomerated necrotic lymph nodes causing partial compression of the left mainstem bronchus. Now, having known this, Ankit sir, what would be your possible differentials and what do you do next?
Uh, so I think it depends on the epidemiology. If you have a 2-month-old, and in the Indian setup, where tuberculosis is very high on the cards, do thoroughly look at the history of the mother. Because if a 2 months old gets tuberculosis, then it has to be maternal or a close contact with the family member, which has led to tuberculosis. Also, I would like to see the lung window as well. That do we have any parenchymal lesion, which can give us a good idea about the diagnosis.
There were no parenchymal lesions. I don't have the lung window here, but we went through this. There was no parenchymal lesion. The lung apparently was normal. So this was our thought process as well, but there was no TB contact as well. There was no nearby history, or even the mother was absolutely fine. And this child was well grown. So, as given by the radiologist, the close differentials, they even thought of something like a lymphoma. Early lymphoma could present like this. So, gastric aspirate were sent, which was negative. gene expert AFB, everything was negative. ESR was slightly raised. MAN2 was positive, but this child is young, just received BCG. And MAN2, any which ways, has no clinical role as of now. For malignancy, there is no cytopenia. Peripheral smear was normal. LDH was normal. So, having known this, we went ahead with bronchoscopy. And again, as expected, there was partial compression of the left mainstem bronchus, causing almost near or complete occlusion of your left mainstem intraluminal bronchus. And that was the reason why this child has developed left-sided hyperinflation, causing mediastinal shift to the right side. And hence, this finally, for tissue diagnosis, this was the child which underwent something called as EUS-B-FNA. So the same lymph nodes, since these lymph nodes, which ideally should be mapped through trachea, you cannot pass an eboscope in such a young child. So the same lymph nodes were mapped through the esophagus, and biopsy were taken from this child. And this was one of the youngest child which underwent this procedure as of on literature. Now, comparing the BAL and your lymph node reports, the BAL was still negative, but the lymph node showed gene expert positive, rifampicin sensitive, AFB1 smear, and necrotic lymph nodes with epithelioid cells on histopathology. Now, having known this, is this over? Or should we further? We know that this is TB now, but a 2-month-old having such bad necrotic lymph nodes, should this raise our red flag? Like, is this a red flag sign, sir?
Yes,
Pallab,
so
sir.
this could very well be immunodeficiency. So we should screen for immunodeficiency, and we should do an HIV screening for both the mother as well as the child. And also we should start doing the contact tracing and find out who's the contact. But immunodeficiency will be very high on our cards.
Right. So that is what our thought process was, and hence all these immunological panels were sent. This answer we didn't have,
So just
but
one
where
question,
possibly this.
So,
Yes, sir.
was there any dissemination like liver, spleen, palpable, or
No.
other side axillary lymph node or any other lymph node?
No,
Because
sir.
the child has received just BCG, and it could be just a
Yes.
disseminated BCG also if you're talking about TB or you're talking about immunodeficient child getting into this type of problem. I mean, just a lateral thought.
If you say about BCGosis, the ipsilateral lymph nodes, the axillary lymph nodes were normal. There was otherwise no lymph nodes, other lymph nodes were palpable. Liver was not involved. We told them to involve in the CT to look for liver lesions also, which was clean. No
Correct.
parenchymal lesions. It was only mediastinal lymph node, necrotic or conglomerated lymph nodes which were seen.
No, I'm
So
not
this
saying
last
this
question,
child. In general, that's one
Mhm.
thought process you should keep in mind.
Right, sir. So as Pallab sir said, yes, we thought about immunodeficiency, and this child is being worked up right now. The final question, we didn't even I don't have an answer for this because we don't know from where this child has got TB. This is not perinatal, we cannot say. The mother is totally fine, but contact tracing, as Pallab sir said, that we need to do it for this child. So an infantile tuberculosis is mainly, as we know, is a paucibacillary infection. The diagnostic tests have very low sensitivity. Very early onset TB, we have to suspect PIDs, and they go hand in hand with clinical, radiological, and tissue. All these three should meet together in order to finally prove or disprove whether this is tuberculosis. So this is our team where we conducted the youngest EUS-BFNA in Jupiter Hospital, and which is being reported right now. So this second case is an infantile lymph node TB, which again not very commonly seen, but again with this advanced modalities, it can be picked up as early as 2 months of age.
So, Kaustubh,
So next case, this is a yes, sir.
Did you consider getting an endometrial biopsy for the mother?
We have. So that is also actually done. This case was done 3 days back, sir. So that is under process. So that all immunological workup as well as the Cox workup from the mother's end is being done, sir.
But the other question is that if we do not have access to EBUS, what would you have done?
So again, if you ask me, if this child would have come 10 years back, either you would have started AKT empirically, or the other thing that you used to do was mediastinoscopy. But again, in such small kids, it's not a feasible option because there are many major lymph nodes which come in between. Now, having known that all these advanced modalities are present, and again, not very expensive, I would say, if you get into all these schemes as well as you do it under charity, this is something which is new, which is helping us to find the clinical diagnosis, sir. I cannot blanketly tell that this can be used everywhere, but at least wherever it is possible, I think it's well worth doing it, sir.
Yeah, I
What
agree.
about a CT guided? What about a CT guided FNA of the mediastinal
The
nodes?
lymph nodes were too the lymph nodes were too deep, sir. If I'll show you this again.
Yeah, it is
The
going to be quite difficult with the CT
Yes.
guided biopsy. It will lead to a pneumothorax.
CT is right, sir. So CT was not possible knowing that these lymph nodes were so deep. So even if you do CT, you have to go either transpulmonary, which will cause
Yes.
pneumothorax, or this, and you cannot go like either any of these lymph nodes would have been peripherally. CT guided would have been one of the options, but in this specific case, there was no other option other than EUS.
So I think the only other option would be because anteriorly you have a thymus, you don't have nodes anteriorly. So you cannot go with the ultrasound anteriorly. The only way is to put the child prone on a intubate the child, put the child prone, and access nodes with the CT, the nodes which are closer to the right main bronchus. That is the only possible window which you have. But again, as Kaustubh said, you have to go through the lung and you will have to tolerate a pneumothorax. So I think that is the only other way uh, people can do it. Uh, the most conventional way, which everyone else would do it, is to put this child on ATT with steroids.
Yeah, so that was what we've been practicing in the past. But now knowing that the NTP program focuses on DST, it's rather we should be finding the bug before treating it. Right. So coming to our next case, this is a 5-year-old male child, complains of fever for the last 7 days, progressively increasing cough, breathlessness since last only 2 days. So the very acute history. Well child, no past history, vaccination complete, no family contact history. On presentation, there was generalized edema. As you can see, there is periorbital edema, significant scrotal swelling, distended abdomen, was tachypneic, there was labored breathing, prolonged expiration, air entry was markedly reduced in the right upper zone, and there were creps heard only locally. So having known this sign with other general conditions, Ankit sir, what are we dealing with?
So you're dealing with a generalized edema, and uh, I think the first possibility which someone will keep is angioedema, uh,
Mhm.
which has been incited because of something. You have to look at the other signs to say whether there is any anaphylaxis or not. The second possibility could be a nephrotic syndrome, which can present with generalized edema. Uh,
Mhm.
I think these.
But collaborating with his respiratory concerns, a generalized edema with the respiratory concerns and significant such bad scrotal swelling.
So most commonly would be an urticaria or angioedema, which gets precipitated uh, with any viral or bacterial infection. So most of these urticarias, angioedemas, they get triggered with viral infections or bacterial infections. But directly, if you say that if you're not dealing with an angioedema and having a cause which leads to a pneumonia and generalized edema, I don't think anything else come to my mind at this point of time.
Right, right. Let's move ahead. So Pallab sir, what would you do for this child with this clinical
Yeah,
presentation?
so I would also think of nephrotic syndrome, probably some capillary leak which is happening. Maybe some cardiac failure can be there. Severe sepsis that can also lead to some capillary leak. But given the periorbital edema, the scrotal edema, the abdominal distension, so nephrotic syndrome would be very high on the cards. Along with that, there is some problem with the airways, so there is some lobar pneumonia or something that is there. So I would rather also look for very rarely could be some bronchial tumors which can present like this endobronchial foreign body, but it's not that it should that common. Pulmonary edema from nephrotic syndrome, cardiac failure, all that should also be high on the list. So I would do urine test. I would do a spot urine protein, 24-hour urine protein creatinine ratio. Look at the serum albumin, renal functions, sputum or bowel cultures if possible, blood culture, and would also definitely do the usual routine blood tests, chest X-ray,
So one thing
maybe an
which I
ultrasound.
would want to point is the respiratory signs are very focused. It's only in the
Yes.
right upper zone. Anything that can correlate with these findings?
Yeah, so I would like to do a bronchoscopy to find out what is the reason for this right upper lobe thing, whether there's a mucus plug that is obstructing there, where there's a foreign body that is there. So I would rather do a bronchoscopy quite urgently to find out what is the cause over there.
Right.
So what
So
about the blood pressure of the child?
blood pressure is normal, sir. I have not mentioned it, but it was normal. Out of all the tests that you said, sir, urine protein creatinine ratio was normal. Serum albumin was on the lower side. So that was just one, but not significant low. It did not require albumin transfusion per se. So this is a CBC, WBC of 9.68 with 77.8% neutrophils and neutrophilic predominant. Otherwise, CRP was significantly raised, 212. Nasopharyngeal swab grew, rhinovirus and enterovirus. And this is the X-ray. So these are two serial X-rays. So Hiren sir, any comments on the X-ray, sir?
Yeah. There is a dense right upper lobe consolidation. On the left side, there is some lingular collapse also. There is a collapse margin of the lung, you can see, left upper lobe. And there might
Right.
be some
So more
retrocardiac, left-sided retrocardiac might be infiltrates.
right. So more or less it is bilateral involvement, but as you can see, it's a very dense involvement, dense opacity in the right upper zone. And would you label this, sir, as a consolidation or a collapse? Like we usually say collapse consolidation, but would you like, is it the airway involvement or a parenchymal involvement? Just based on X-ray, just grossly.
Probably consolidation.
Consolidation. So again, as there is no significant
I
volume
can see
loss
some
as of
bronchogram,
now,
air bronchogram. I can see some
air
air
bronchogram.
Yeah.
So on the second X-ray, you can see some. The first X-ray, probably there is nothing that can be seen. So, Ankit sir, having knowing this, what next?
So I think first we need to see what this child is doing for the first 48 to 72 hours with the conservative treatment which we have done. So what has happened to the clinical status, the vitals, the respiratory distress, the edema, the general condition, and looking at that, then we can plan further.
Right. So that is what we did. We put this child on HFNC support. We started on IV antibiotics, piperacillin, tazobactam plus vancomycin to cover your MRSA as well as your gram negatives. IV fluid just given. Again, any role of nebulization? Ankit sir, you can take this in this child.
Well, if you find this child is having a wheeze on auscultation, then you might add that. But with these large amount of pneumonias, usually no.
Right. So one thing that we should take in mind that nebulization is not for all causes of respiratory problems. Only when you isolate what problem there is specifically, then we can see. But would you want to, knowing the fact that there would be some airway involvement, would you want to do some hypertonic saline nebulization or N-acetylcysteine nebulization in this child?
Well, hypertonic saline nebulization, also leads to a bronchospasm, and it is only approved for patients with cystic fibrosis or occasionally with bronchiolitis. So not all patients should be nebulized with hypertonic saline because itself it leads to a bronchospasm. Well, again, as I said, N-acetylcysteine is not something which has been really approved or improves collapses. Sometimes we do that when you want that this child collapse opens up and you don't want to do a bronchoscopy, we occasionally try that, but I think we don't have significant evidence for it.
Right. Excellent.
One question, Kaustubh, just go back to
Yes,
the
sir.
slide. Why piptas treated? I mean, is a child not exposed to any hospital infection, is otherwise well child. Commonest would be either a pneumococcus or a staphylococcus or an atypical. Why not
Yes, sir.
ceftriaxone plus vancomycin rather than piptas?
That's my next question, sir. That's my next question. Are we giving
Oh,
correct
sorry.
antibiotics?
Sorry.
So, Pallab sir, are we giving correct antibiotics?
Yeah, see, this child, no, I would rather think of some encapsulated organism, so probably a strep pneumoniae, H. influenzae. I would, if MRSA is, trying to cover MRSA, vancomycin is fine. Piptas, tazobactam is also okay, but I would rather think that I would start with ceftriaxone, vancomycin, rather than going for a piptas, vancomycin, because
Right.
I would like to cover the strep pneumonia and the H. influenza in this child.
Agreed, sir. So since this child was already put on, had received multiple antibiotics from the referring hospital itself, for the time being, we didn't change any antibiotics, but there was no adequate response. There was persistent fever, distress was still there. Now, Hiren sir, what do we want to do next? Would you want to directly jump on to Scopy or would you want to do a CT first?
I think we have pretty good idea about where the collapse is and where the consolidation is. So if you want to look at the mediastinum or some nodes, probably CT would be, it's a non-invasive test. So it's better to go for a CT first. And then ultimately we know that we will have to go for bronchoscopy to remove the mucus plug or
Right.
cast
Right, sir.
bronchial.
So that is exactly what we did. CT was done. They showed dense consolidation of right upper lobe. Bronchial cutoff was observed in the right upper lobe bronchus, which says that there is something which is obliterating the right upper lobe bronchus completely and not allowing the right upper lobe to be aerated. There is consolidation of the lingular segment of the left lobe and no enlarged mediastinal lymph nodes. Now, one thing which was also said by the radiologist, the lobe looks so dense. It could be that there is some intraparenchymal malignancy, which is causing compression effect on your nearby major vessels and causing your edema. But later, again, that was disproved by what we did next. So again, Ankit sir, infectious or non-infectious?
Well, I think at this age, infectious possibilities would be the first. It would be hard to think about non-infectious possibilities. So occasionally you do get things like pseudotumors or something which can present with this. Uh, Mycoplasma is something which sometimes can misbehave and present like this. So infectious possibilities should be kept, high up on the cards compared to non-infectious possibilities.
Right.
So
So
Kaustubh,
yes, sir.
just because you talk of
Yeah.
oncology, I cannot resist but to open my mouth. I mean, which are the malignancies which will come in the chest primarily and have systemic issues? Like, Burkitt's lymphoma, which can come with massive edema, hypoproteinemia, and it's very sick child, progressive. Most of them come with abdominal mass rather than thoracic. And in thoracic,
Yes,
is
sir.
the T cell, which is more important, and they usually come either with a huge mediastinal mass or with a pleural effusion, but not with bilateral consolidation like this. That's very
Right.
unlikely to be malignancy.
Agreed, sir. So that was one differentials given by the radiologist.
Yeah,
So
correct.
just thought of clearing it out. So we went ahead with a bronchoscopy and surprised to see that the whole right upper lobe was filled with this dense mucus plug, which on aspiration took the shape of the right upper lobe bronchus. So this is very classically said as bronchial cast and very rare in such an acute cause. I mean, acute phase, only in 7 days, 7 to 10 days this bronchial cast or what we call as plastic bronchitis. Plastic bronchitis is usually used in post-cardiac surgery patients, but this bronchial cast with streptococcus was something which was not very common in our usual practice. And once immediately post-procedure, post-toileting, as you can see, that this was the first X-ray in which you could practically see no air bronchogram. And immediately after post-toileting, airway started opening up, and 2 days post-procedure almost was cleared. And subsequently, after a week, was normal. So this was something which infectious but causing significant physical obstruction to the right upper lobe bronchus by bronchial cast. So bronchial cast or plastic bronchitis is mainly this formation of thick or tree-like cast in the airway which completely obstructs the airflow. It is usually seen in post-cardiac patients, mainly in fontans. Rarely, it is also seen in post-infectious like influenza, adeno, or RSV. In this case, it was post-streptococcus. So that is something which we didn't expect. And immediately after doing this procedure, all these complaints gradually came down. So it was probably an inflammatory reaction to that localized pneumonia, localized obstruction of the airway, which had generalized symptoms. And as this was relieved, his hypoproteinemia got corrected, his CRP is downtrended, his fevers also came down. So this was a case of bronchial cast. Now coming to our last case.
Kaustubh, that brings us
Yes,
back to our antibiotic stewardship. That when
yes,
you have a pneumonia which is community acquired in an otherwise healthy child, not suspecting immunodeficiency or is not exposed to hospital in the past, the first line of drug is ceftriaxone. You may
ceftriaxone.
add vancomycin or a staph cover if there is breakdown, or if he doesn't respond, maybe an atypical based on your epidemiology. If you have a mycoplasma outbreak, always cover with mycoplasma upfront, and so on and so forth. I don't know
Agreed.
what antibiotic the child received before he came to you, but I'm sure they must have hooked up with meropenem, vancomycin, piptal,
Yes.
anything except ceftriaxone.
Yeah, very true, sir. So this was
Kaustubh,
again, yes, sir.
just
Yeah.
yeah, just 3 days back, we had a child, 28 weeker, 920 grams, and right side was totally collapsed, so we couldn't open this child. Child was persistently on CPAP, and like severe distress was persisting. So we did a bronchoscopy, and we were surprised to find a bronchial cast in such a young child, 12 days old. So
Mm.
it was a two casts came out actually, and the
Right.
lung improved. So we are seeing such cases. I don't know whether they are so much reported in literature, but it's happening. Yeah.
Yeah. But
This is what
usually
we
it's been
call
reported that,
this is what you call
yeah,
reference
please.
bias.
Excuse me, sir.
These are called reference bias. Such patient only will come to the pulmonologist. They will all get filtered at the pediatrician
No,
level
no.
first.
This patient
No, no,
was
yours is a very different.
I was the pediatrician who was present during delivery. So this patient was my patient only.
Yeah. So how many such
Wasn't
patients you
referred.
have seen in last 10 years, 15 years?
No, no,
Maybe
no, no, no. 920-gram old with bronchial cast I've never seen.
that's what I'm saying. These are rare. What I mean is the delegate should not go with the feeling that plastic cast or the
Yes,
plastic
yes,
bronchitis
yes,
is
yes,
the
yes, yes,
number one
yes.
Yeah.
diagnosis in such patient. It would still
This
remain
is,
some
yeah,
infection which you have either
Absolutely,
miscalculated, mistreated, or you have not investigated properly.
absolutely,
right.
absolutely.
Right, sir.
What
So
we
coming to our, yeah,
in
yeah,
India is basically inflammatory cast, uh, and one or two cases a year is something that we see.
Correct.
We have had two patients where they presented with complete left-sided collapse, and they were referred for removal of a foreign body which wasn't there, and it was a cast which was there, and that came out. One child had two times plastic bronchitis, and we weren't able to prove what it is. Uh, One child grew Boca virus. Occasional children have grown staph. Uh, and it is a bad disease, and we lost one child. That child was tracheostomized, but even then the cast actually blocked the tracheostomy, and that child passed away in the ICU. So that's one. Second is that in such situation, anyone who is doing a bronchoscopy uh, should take help with the cryo, because these casts have a good amount of water content. So blood clots and cast, they are very good indications of using a cryo. Because when your bronchus is totally blocked with cast, you just juggle around, pushing around saline and moving it. And because you're using thin scopes, it is very difficult to remove these cast, because it doesn't get back into your channel, and your channel gets blocked again and again. So I think if you have an access to cryo in such situations, that would be a real asset. Now we have access to cryo for the past 1 or 2 years, but when we did not, it was a bad scene. Removing cast, especially in a child who has a complete lung collapse, is a havoc, because these children keep desaturating, and you're just not able to remove it.
agreed, sir. Agreed. So
Yeah,
cryo
so
makes
what
it
we
very
what,
easy.
yeah. So what we do is, like, if you don't have the cryo, so the hospital where I did it, this cryo wasn't available. So suction and let the thing be stuck to the bronchus and take out the whole thing as in toto. So that is how we removed the gas, because
There have
that
also been
hospital.
attempts of local installation of N-acetylcysteine, sir, subsegmental installation of N-acetylcysteine, which helps to remove this cast much more easier.
Okay.
So that was about the third case. Now moving to our final case. This is a 8-year-old boy. A relatively short case. 8-year-old boy complains of episodic coughs in the last 2 to 3 years. There is no respiratory distress. There is no fever. The cough is episodic in bouts, each lasting for 3 to 5 minutes. The face turns red with cough and occasionally post-acid vomitings. The frequency is gradually increasing over the period of time. There are no other complaints, otherwise well-grown child. This is how he's coughing.
Sound?
Can you hear the sound, sir?
No, we can't.
No.
Oh, okay. Then how do I?
Because you have to connect it to your laptop, the sound system. I don't know how you do it.
No, you
You
have
Uh,
to
can
go to the
You have to,
setting of
yes, WhatsApp,
the
Zoom.
WhatsApp,
Go to
not
the
not WhatsApp,
Zoom
of the
setting.
Zoom, and then
uh-huh.
you have to switch it
When
on.
you're logging
So
into Zoom, that is the time you have to choose the audio also, connected
yeah,
audio. Yeah. So you may
Uh,
have to log out and log in again. And
No,
while
it's okay.
login, if there is a
let it be. You
Describe the
okay,
discuss
cough.
it, or
Describe
you
the
okay,
can
cough.
okay.
cough it.
So this was typical. I cannot cough this way, but this is a typical barking sounding cough,
Correct.
very loud sounding cough. episodic, such bad that you can see that he's tearing and you can see the whole bowl of secretions falling below him. Used to stay for some time. No medicines used to work for this child. So just by the sound of this cough, okay, matlab, if this would have been audible, it would have been very nice. But uh, whenever you get a barking sound of cough, Ankit sir, where is your site of affection? Where is your pathology? The site of pathology?
See, classically, it is a tracheitis or a tracheomalacia type of cough, which you can consider. Uh, but it depends on the history as well. Is it whether it is acute or chronic? Is it persistent or it is intermittent? What happens to the child otherwise? Uh, so
So
I
this is
think
a well-grown child, sir. This is a well-grown child. Last almost 3 years, he started coughing. Initially, not much cough. Was initially diagnosed by an outside pediatrician. Was put on some inhalers, saying that it could be wheeze, but no response at all. He's still coughing, but now day by day, this bouts have the frequency are increasing.
well, if you don't have any wheeze and this cough is persisting, look at upper airway, look at postnasal drip. That is something which we all would do. Uh, Habit cough sometimes can be a big nuisance. I understand it is more of a barky and not like a honking character, but habit cough sometimes can be a big problem.
Right. So otherwise, this child is a well-grown child. No tachypnea, no
What
distress.
about protracted bronchitis type of cough?
That is wet-sounding cough, sir.
There's
Hmm.
wet cup.
So
That is wet cough.
he has been
He
pouring
is
a lot
dry.
of.
Though this is post by khas के
Oh,
लिए उल्टी कर रहा है.
he's vomiting.
Suppose
Okay.
the
Yeah, he's
child
vomiting it out.
Gastroesophageal reflux, could it lead to such cough, trigger such cough?
Yeah, but again, at this age group, well-grown child, sir, that thoda is unlikely.
How's
I
the
would
So
like
child
to know
during the
what is
sleep?
happening at night when the child is sleeping.
Yeah.
he has intermittent cough, sir. He does get up with cough at night also. So it's not that it is not like typical habit or psychogenic cough. He has episodes even at night, not as frequent as in the morning hours, but the sound of the cough is very concerning. It's loud, honking, barking kind of cough. So
Yes, sir.
again, basic investigation as we did. Ankit sir, anything on the X-ray?
Yeah, I think it looks normal to me. Nothing really on the X-ray.
Excellent. So that was what even our first thought. So how do we treat this kind of cough?
Uh,
Hiren sir?
I don't know the etiology of the cough, so it could be habit cough, as Dr. Ankit sir said, uh, or it could be some laryngeal penetration going intermittent laryngeal aspiration, micro aspiration occurring, maybe
Okay.
G reflux or some achalasia or something causing.
Right.
Is it
So
related
having
to male feeding after meal or something?
no sir, no relation with feeding.
Hmm.
Otherwise has no vomiting. Without cough, this child doesn't have any vomitings, no retchie feeling or nothing, no symptoms for reflux. But this cough, as Ankit sir has said, is predominantly this upper airway side, matlab your proximal airway cough. So for this, Ankit sir, how would you manage this child for a
uh,
tracheal cough?
yeah, so I think if you are thinking beyond a psychogenic cough, it is persisting at night. Um, uh, uh, so psychogenic cough obviously would be absent at night. You have done a psychological assessment as well. Then I think you need to go ahead and investigate the cause of cough. You just cannot do something about the cough unless until you know what you're dealing with. So if that is the situation and you do not have a diagnosis, consider doing a CT of sinuses, looking at a real bad sinusitis, which sometimes can be the cause, or consider doing a CT chest or a bronchoscopy to look at something else.
Right. So as we were having absolutely no clue, all the blood investigations were normal. We went ahead with yeah. So Pallab sir, CT or bronchoscopy in this case, knowing that
Uh,
this is the X-ray.
so yeah, I would rather go for a bronchoscopy because it is diagnostic and probably therapeutic in certain cases. And CT, yes, if we suspect any structural disease, any vascular abnormality, then we would do a CT scan. But just for isolated cough with normal examination, we would not jump to CT first. We would rather go ahead and do a bronchoscopy.
Excellent. So that is what we did also as well. As we went inside, normal upper airway structures above the glottis, even though not shown, was normal. Now, as we went down, we just above the carina, we saw something which was not normal. You can see that there is pulsations which were seen just above the carina, which was exactly correlating with the heart rate. So there's external pulsatile compression in the distal trachea just above the carina. So some thought process of some vascular structure is compressing from the outside, from the external part of your trachea, which probably could be irritating the airway and causing cough. Now we went back to our drawing boards. Again, this is the X-ray. Focused a bit just on the X-ray. What was this? So this was something which was not normal. Usually you see this on the left side. So even on X-ray, had we just focused on the X-ray a bit, the diagnosis was facing right at us. This was actually a right-sided aortic arch with an aberrant subclavian artery. And this aberrant subclavian artery, it formed a sling-like structure around the trachea, and that caused a compression of the trachea from outside, and that was the irritating thing. Now, the only question is why this child developed cough after like 5 years of age. Initially didn't have it any, but over a period of time, this cough started increasing, probably because this compression went on increasing. Cause we don't know, but that was how he presented. So this was surgically corrected as this sling was released, and this was a surgical way of treating cough. So whatever medications you gave, this child was not responding, but just by this procedure, post-procedure, this cough just vanished away. So vascular compression either could be an aberrant vessel that can cause an external compression to trachea or primary bronchi. Pharmacotherapy will not give definitive results, and the definitive treatment stays surgical correction. So, either of the panelists, have you witnessed such kind of cough in which any surgical correction was required?
Yes, one of my patients went to we referred this child to Dr. Thiru, and he was the person who did the surgery, and the child was better. So this child had a sling, a pulmonary sling, which was
Right.
leading to recurrent cough. Yeah.
So one pharmacological therapy which has been postulated, sir, is anticholinergics, which predominantly work in your proximal airway. So compared to your distal airway. Again, there is no hard fact rules. I mean, evidence saying that, but all your ipratropium and tiotropium bromides, they do help in your proximal tracheomalacic cough, and over a period of time in the recovery of these kids, post procedure, they help in reducing the cough. So these were our main four. Sir, can we take the short cases?
Yeah, you have another 10 minutes.
Yeah. So quick cases, one case per panelist. So this is an 8-year-old boy, known case of severe uncontrolled asthma. Presents with progressively increasing coughs in the last 1 month, mild on and off undocumented fever, progressively increasing fatigability, and 2 episodes of blood-tinged sputum in the last 24 hours. So this is an asthmatic, now come with acute exacerbation and also with other symptoms like your blood in sputum. With tachypneic, bilateral V's and diffuse Krebs are present, and this is the CT scan of that child. Because it's a spotter, I've just put what is very much positive. So, Pallav sir, what could this be? Probably.
This could be some mucus plugging, some maybe tree bud changes. So the bleeding suggests there's some bronchiectasis with some airway erosion. So I would think of with the history of atopy and the central bronchiectasis, I would think of an ABPA in this child. So would do the total IG, the Aspergillus specific IG, EIGG, and that's and would like to also do a sputum and a bowel culture to find out if there is something else.
Excellent. So, as sir has rightly said, these are called as halos. So, this is halo sign of aspergillosis, seen in both invasive as well as in some cases of ABPA. The close differentials are like septic emboli, rarely tuberculosis, malignancy, some vasculitic changes, or even in radiation pneumonitis. So, you see these halos, and if they progress ahead, they lead to something called as crescent sign, in which there is central clearing, which are very typical of any fungal infection, mainly aspergillus. Next, this is an 8-year-old male child, again a known case of bronchial asthma. He has been on and off medications in the past. Now comes with gradual complaints of gradual progressive coughs in the last 5 days. Presently coughing violently. There is sudden onset breathlessness, and now this child comes with chest pain. So asthmatic, probably having exacerbation, but now has acute onset chest pain. He's tachypneic, saturation of 92%, bilateral polyphonic wheeze, and crepitus is heard. And this is the X-ray. So Ankit sir, what do you feel? What are the X-ray findings, and what do you feel is this?
I think there's some amount of air leak which has happened. I could appreciate some amount of subcutaneous emphysema in the neck, and there is some amount of pneumomediastinum as well. Because the shadow on the you see a black shadow on the heart. Sometimes you have a thymus which gets uplifted with air beneath. So I think that is what I would think of. A violent bout of cough leads
Excellent.
to some amount of air leak.
You're absolutely right, sir. So there are multiple air leaks all across the subcutaneous emphysema, in your mediastinum, in your pericardium. So this is pneumomediastinum and subcutaneous emphysema, very classically said as Macklin syndrome or Haman syndrome, which is seen in acute exacerbation of asthma. If goes very violently, if it is cough very violently, there are multiple air leaks across your third spaces, and which leads to this typical crepitus, which over a period of time, like for management, Ankit sir, how would you manage this child?
So usually it is a conservative management, unless until your subcutaneous emphysema is so bad that it is not letting the chest expand. But 99% of patients would be managed conservatively. So as the asthma improves with oral or IV steroids with your bronchodilators, this is going to settle down. So I think all the patients who have presented with asthma with air leak, that happens every time in the asthma season, and all of them would improve. Occasionally, you can have a very bad subcutaneous emphysema. Different ways people deal with. What we have done occasionally is you take a 14 or 16 gauge intracath, remove the stillet, make some fenestrations on the silicon part, and then you insert it and remove it. You remove the stillet and leave it open. So you can do it sometimes, but it's quite messy doing, putting some multiple intracats, 3, 4 intracats here and there. So unless until it is very bad, you don't touch it.
Any role of hyperoxygenation, sir?
Yeah, so any child with air leak, being pneumothorax, pneumomediastinum, people would give oxygen, thinking that it leads to an early resolution of the air leak. But not really. Most if this child is not hypoxic, then just the normal management of asthma would settle this child in 48 to 72 hours.
Right. Great. So coming to our last case. So this is a 3-year-old child, known case of partial anomalous pulmonary venous connection, was referred with concerns of cough, respiratory distress, requiring 3 admissions in the last 6 months. Cough was dry, loud, brassy, progressively increasing in the last 6 months. So again, this type of cough is very specific, not responding adequately to your medicines. And this is the X-ray. Hiren sir, what is the abnormality and what could possibly be the problem?
There is a well-defined rounded opacity on the right upper lobe. Probably bronchogenic cyst compressing the
Excellent.
trachea.
Point exactly on target. So this was a bronchogenic cyst, and that was causing tracheal compression and causing irritation. So again, here is a surgical correction of cough, and that this needs to be excised. And once excised, this cough completely vanishes off. And this was also the reason for tracheomalacia, which was causing recurrent pneumonias because of accumulation of secretions. So we saw multiple cases, not so common cases, again, abnormal presentation of common symptoms. So the final take-home point is finally history, and history, because that is going to clinch your diagnosis. Age-appropriate pathology, as the age changes, the etiology changes. At times, you can be surprised with some surprising, what do you say, diagnosis, as we saw in this 2-month-old or a 2-week-old child. Clinical correlation is always important to your examination and your history. And finally, relatively low threshold for your necessary investigation. So as our esteemed panelists were very pro, or I would say had a low threshold to do scopies for most of these things. Again, I don't want to promote that we being pulmonologist, we scope every single kid, but wherever it is required, So we do have to put in a scope, even though you don't get any answers, but a negative scope also is a result. So you've ruled out something which is major. And finally, your eyes see only what your mind knows. So only when you have a clinical diagnosis in mind, then only you'll think towards that diagnosis, and then you'll finally get to your goal.
I
Thank
would
you.
just add, Kaustubh, that rational antimicrobials, because people tend to have more severe
Yeah.
infection, means more resistant, and then get higher antibody. That's not true. All right, so I
Right,
think we
sir.
had an excellent session today with Kaustubh, showing some cases which he has seen in his day-to-day practice, very ably discussed by the three senior pulmonologists, come intensivists, Dr. Pallab, Dr. Ankit, and Dr. Hirenbhai. And we really had a great discussion and good learning, I would say. This will also open up the minds of the delegates to think laterally when the case doesn't behave the way they want. So while the cases shown here may be the rare ones, but they are the ones which are likely to be referred or likely to be missed. So while you may treat an asthma in a routine way, a pneumonia in a routine way, or a small child with wheezing in a routine way, when things don't turn up the way you desire, is a time good to take an opinion. And I think now we have pulmonologists almost every part of the country, and make use of them. And as you very rightly said, as we say that bone marrow is the most the least used what do you call investigation in a patient with hemato-oncology. People are so shy to do a bone marrow. Sometimes, as I say, it's easier to do a bone marrow in a child than to put an IV in a small preterm baby. Same way, doing bronchoscopy is so easy and easily available. It's not that expensive, and you have people who can help you out. It can actually avoid a lot of invasive procedures like doing a CT guided biopsy in the small child vis-a-vis IBUS. I think that was an eye opener. So I'm sure the delegates have gone rich with the knowledge about the pulmonology. And we promise to be back with the next webinar in the month of December, which will be 4 weeks from today. So that comes to around 19th of December. So we'll decide whether it will be 19 or 26 based on the availability of faculty. And we will have one more system covered with the moderator and the panelists being from that particular specialty, and myself and Ramesh being on the Nepathy or on the backstage. With that, we come to an end to today's webinar, which is actually completing dot in time. It's around 10:27, and we usually end at 10:30. So over to Ramesh Bhai for vote of thanks.
So Nitin bhai, as you said, thank you so much, Kaustubh, for wonderful compilation. The approach which you insisted upon was very important rather than the diagnosis. And I acknowledge the presence of our Pune friend, Dr. Mahesh Sulakshanaya also. And next month, as Nitin bhai said, we'll cover yet another system, and let us strive for pure academics. And thank you so much for your valuable time and appreciation, Dr. Parakh, Dr. Hiren Trivedi, Dr. Kaustubh, and Dr. Parab Chatterjee. Thank you, Nitin bhai, for taking all the pain for selecting such amazing faculties and enlightening our colleagues. Thank you.
Good night,
Thank you, sir.
everyone. Have a
Good
nice
night.
Thank
day.
you.
Thank
Thank
you.
you.
Good night.
Thank you.